Good afternoon, everyone. Welcome and thank you for joining us on our Thursday afternoon educational webinar. We are excited to be joined by Dr. Rachna Shroff, who's an associate professor of medicine and chief of gastrointestinal medical oncology at the University of Arizona Cancer Center in Tucson, Arizona. She's a member of the Scientific and Medical Advisory Board, the International Cholangiocarcinoma Research Network for the Cholangiocarcinoma Foundation, and a member of the GI Program Committee for the American Society of Clinical Oncology, ASCO. Her clinical research includes pancreatic and biliary cancers and GI malignancies. We're also joined today with Dr. Luca Fumagalli from Helson's Clinical Research and Head Development of Clinical Development and Scientific and Medical Expert. He has over 10 years of experience in clinical activities and clinical trials in solid tumors for phase 1, 2, and 3. He's responsible for the planning and implementation of clinical trials. We're happy that you guys have joined us today. I would like everyone to know that you can put your questions in the chat box or in the Q&A. We will get to them at the end of the presentation, but feel free to put them in throughout the presentation as you think of them, and we will answer them as best we can. And welcome, Dr. Shroff, and I'll turn it over to you.
Thank you so much, Melinda. Thank you to the foundation and to Helson for inviting me to participate in this webinar. And like Melinda said, my hope is that we spend part of the time going through slides, but really make this as interactive as possible. So please feel free to send in questions, and I look forward to an engaging discussion. So I will start and share my slides. So as you all know, this session is really focusing on what I think is an incredibly exciting space of drug development, and that's the targeted therapy world in cholangiocarcinoma, and specifically looking at targeting the FGFR2 fusion pathway, looking at trials with Infigratinib in particular. And as the Cholangiocarcinoma Foundation and everybody in this space knows, this has really been, I think, an area that is a model for precision oncology. I keep saying that cholangiocarcinoma and biliary cancers is really a shining example of how we can develop targeted therapies that provide meaningful responses and kind of life-altering experiences for patients. So this is our agenda, and like I said, this is only like 25 slides, but we're going to kind of go through a bird's eye view of molecular testing, Infigratinib in the second line setting, and kind of talking about what the data is up until now, and then kind of talking about where the future lies and ongoing trials. And then we'll open it up to Q&A. So for those of you, I'm sure this is not new information, but cholangiocarcinoma is one type of biliary tract malignancy. It is also known as bile duct cancer, and it is the most common biliary tract malignancy. The honest truth is that most patients, I have a lot of patients who will come to me and say, well, why did I get this? And unfortunately, in most patients, we don't really know why they develop cholangiocarcinoma. And you can see in this graphic here that the anatomy of the liver, the biliary system, and kind of the pancreatic system are all very tightly interconnected. And cholangiocarcinoma are cancers that start in the bile ducts. These are the ducts that basically line your liver. I describe them as the plumbing of the liver, and they form a very beautiful tree branching pattern through the liver. And so any of the biliary bile duct cancers that start in the higher bile ducts or the intrahepatic biliary system, those are intrahepatic cholangiocarcinomas. Then the larger bile ducts, all the small bile ducts kind of come together and form ducts that are the common hepatic duct as well as the left and right hepatic duct. These are all right at the entrance of the liver, and these are kind of the perihilar, as we call them, cholangiocarcinomas. And then any sort of biliary tract cancer that starts in the common bile duct, which is the main bile duct that runs outside of your liver, those make up the extrahepatic cholangiocarcinomas. Now, unfortunately, half of the reason that a lot of patients present with advanced stages is because there is not really effective screening for this disease. We don't have, a colonoscopy. We don't have a mammography. We don't have something like that that helps us find this at earlier stages. And as such, about 60 to 70% of patients present at an advanced stage. Advanced simply meaning that it has grown so large that it cannot be cleanly cut out with a surgical procedure, and or it has metastasized or spread to multiple areas of involvement. The majority of patients are of older age, greater than age 65. I will say that we have noticed kind of a slight younger onset recently, and that is kind of probably going to shift the median age downward over time. And there's a lot of research going into trying to understand that change. I already kind of went through the anatomy, but when it comes to intrahepatic cholangiocarcinoma, it accounts for about 15% of all primary liver tumors. And liver tumors are a little bit complicated because liver tumors can be primary liver cancer, hepatocellular carcinomas, intrahepatic cholangiocarcinomas, or metastatic disease from other adenocarcinomas, breast cancer, lung cancer, pancreas cancer. These are all diseases that move to or metastasize to the liver. But 15% of all primary liver tumors, HCC, hepatocellular carcinoma, and cholangiocarcinoma, are accounted for by intrahepatic cholangio. The 5-year survival rates, because most patients present at advanced stages, is low, 7 to 20%, depending on kind of stage and presentation. And in the United States, we see about 5,000 newly diagnosed patients with cholangiocarcinoma every year. But it's tricky because of the data. It's not always as clear. Sometimes everything is lumped together as liver cancer, and sometimes those are bile duct cancers. Carcinoma of unknown primary is sometimes actually cholangiocarcinoma. So there's a variance there, and there are some sources that indicate that we're looking at about an incidence of about 8,000 patients a year in the US. Now, the standard of care for cholangiocarcinoma, this slide has been pretty much unchanged for some time. When we have localized non-metastatic disease, i.e., an isolated tumor, something that is just confined to where it started, the curative approach, the only curative approach, is surgery. And obviously, that is our ideal, to get patients to the operating room. Oftentimes, when they undergo surgery, there is still a chemotherapy component. Historically, that was surgery followed by postoperative or adjuvant chemotherapy. Nowadays, we're starting to see a slight shift in terms of our approaches to cholangiocarcinoma, and we are using more and more what's called neoadjuvant chemotherapy or preoperative chemotherapy. In the unresectable, so meaning locally advanced, so too large to cut out or technically unresectable, or metastatic space, the standard of care has been chemotherapy historically. In the newly diagnosed patients, that standard of care has been gemcitabine and cisplatin based on the ABC02 trial, which was a trial done in the United Kingdom. I will say that we've very recently had some changes to that, and potentially some more changes coming soon. But the TOPAZ-1 data that came out earlier this year suggests that the addition of durvalumab and immunotherapy to gemcitabine and cisplatin could be a new frontline regimen to be considered. And there are a couple other first-line therapy studies that are ongoing, and we're awaiting readouts on those. So our hope is that we can build on GemCis and do better than GemCis. In the second-line setting, chemotherapy, again, is kind of been the backbone. It has been all over the place. The NCCN guidelines has a list of 15 different things. It's primarily gemcitabine or 5-fluorouracil based combinations. The two, I would say, kind of most commonly used approaches in chemotherapy are 5-FU based regimens, because most patients get gemcitabine in the frontline setting, and that would be FOLFOX, which is 5-FU and oxaliplatin based on another trial done by the ABC group. And then Naliri 5-FU, which is liposomal irinotecan with 5-FU. Now, I will say that there is a carve out for immunotherapy and targeted therapy in the second line space that is included in the guidelines. So anybody that has what's called microsatellite instability high tumors, this is a specific test that is done during comprehensive biomarker testing. Those patients are eligible to receive immunotherapy, pembrolizumab specifically. And that is unfortunately only about 1 to 3% of cholangiocarcinomas. And then there's the carve out for targeted therapy, and that includes, probably out of the more common ones, FGFR2 gene fusions with therapies such as Infigratinib and Fumagalli, and IDH1 mutations, which includes therapies like ivosidenib. And so, to me, the key takeaway here is really that molecular testing is imperative because it allows us to identify the molecular drivers in a tumor. And a lot of these alterations are what we call early drivers, meaning at the time of diagnosis, we identify them on comprehensive biomarker testing. And that really is important to get right up front so that we can tailor a precision-based approach to these patients. These are the results. This is where we're at when we're talking about gemcitabine and cisplatin. Don't get me wrong, it was absolutely a positive study, and it is absolutely an important therapy for our patients. But as you can see, it leaves a lot to be desired. The median overall survival with gemcitabine and cisplatin in the ABC02 study was 11.7 months, so a little under a year. Median progression-free survival, meaning the time to disease progression on therapy, is only about 8 months. And so we know we can do better, and we should be hoping to do better. When it comes to the second line setting, this is the ABC06 study. And in these patients, this was second line treatment. They were advanced patients, unresectable or metastatic biliary tract cancer patients who had already received gemcitabine and cisplatin. They were randomized over between what's called active symptom control versus active symptom control with FOLFOX. Active symptom control is a little bit different than what has historically been called best supportive care. It's the idea of seeing the physician still every 4 weeks, managing biliary drains, things like that. I will point out that in the UK and in Europe in general, gemcitabine and cisplatin is only given for 6 months, and then patients are followed until progression. Same thing with FOLFOX. So in this study, patients only received 6 months of FOLFOX, and then it was stopped. Primary outcome was overall survival. And again, as you can see here, it was a statistically significant improvement in overall survival, but the absolute improvement went from 5.3 months to 6.2 months. You will start to see a separation of curves later on, as you can see that maybe the benefit of FOLFOX is noted when you look at the 6-month survival rate and the 12-month survival rate, more so than maybe the median. I think the median doesn't always tell the full story in cholangiocarcinoma. Secondary outcomes included response rate and progression-free survival. And as you can see here, response rate was pretty low, 5%, and median progression-free survival was 4 months. So again, in the second line setting, I think it's really important to point out that the bar is pretty low. We can and should do better for our patients after gemcitabine and cisplatin. This is the TOPAZ-1 data. This is what I was just alluding to. This is durvalumab with gemcitabine and cisplatin in patients with advanced biliary tract cancers. This was a little over 600 patients that were enrolled. I think it was 685. Patients were randomized 1-to-1 to receive gemcitabine and cisplatin with placebo versus gemcitabine and cisplatin with durvalumab, which is an immune checkpoint inhibitor. Now, again, because of across the globe what happens with GemCis, in this study, patients continued the GemCis component for 6 months, and after 6 months, continued on durvalumab maintenance, so an immunotherapy by itself, versus placebo maintenance. And again, here you can see that there was a statistically significant improvement in median overall survival with the addition of durvalumab, 11.5 months to 12.8 months with a hazard ratio of 0.8. Again, the numbers, I think the medians don't tell the whole story. It's really as you start to see the separation of curves over time. So this blue line here is the durvalumab arm. And you can see that the 12-month overall survival, 18-month overall survival, and 24-month overall survival, a more striking separation at each of these landmarks. I will point out it's about 25% of patients versus 10.4% of patients, but that's only in 13 patients. So over time, the numbers made it smaller and smaller. And so it was a little harder to understand the true magnitude of benefit. The response rates with GemCis plus durvalumab was 26.7% versus 18.7%. So about a 25% response rate, which is similar to the GemCis response in ABC02. So let's talk a little bit about molecular testing. That's where we're at. That's the landscape of what we're looking at in chemotherapy. What we know about the importance of molecular testing really stems from the fact that tumors are caused by different types of genetic changes. I always describe to my patients that these are mutations. They're what are called somatic mutations. These are not mutations you are born with. These are mutations that you acquire over your lifespan. And so over time, as more mutations accumulate, you get mistakes, if you will, in the genetic makeup. And that is what leads to kind of dysregulation of cell growth and cell metabolism and to the development of cancer cells. But identifying what specific types of mutations may have caused one person's cancer versus another person is really important because it's not always the same molecular landscape. And so leveraging this incredible technologies that we have nowadays to understand those genetic changes in every individual is basically the hallmark of precision oncology, or developing personalized therapies. So the different types of changes we can see are variable. So some include things like chromosome rearrangements. These are what are called fusions, where you have, this is a chromosome right here, and you will see that there's a break point. It kind of breaks right where that box shows. Another chromosome breaks right where this box is, and then they come together. They're fused together. So those are break points in chromosomes that lead to dysregulation. An example of this is, of course, the FGFR2 fusion in cholangiocarcinoma. Also NTRK fusions, which are rare but important and across disease types. The ways that we detect that, as you can see, include next generation sequencing, as well as what's called FISH, fluorescence in situ hybridization. Now, fusions are different than DNA mutations. These are changes in the DNA makeup. Sorry. These are changes in the DNA makeup and can occur at both the DNA level, and sometimes can be found on full next generation sequencing, as well as doing basic what's called PCR, polymerase chain reaction of DNA and RNA. So these are very different. These are mutations, specific changes in the DNA, and include FGFR. So FGFR mutations are described, for instance, in bladder cancer. And then we know BRAF mutations, like V600E mutations in melanoma, as well as in cholangiocarcinoma. 3 to 5% of patients have BRAF mutations. That is, again, separate from gene amplifications and gene loss. These are things that include amplifications in the FGFR2 genes, and these are different. These are found, for instance, in gastric cancer, as well as HER2 amplifications, which are seen in breast cancer, but again, can be seen in biliary tract cancers as well. These can also be identified by next generation sequencing, as well as FISH. And then finally, we talk about overexpression. Overexpression is done at the protein level. It looks at how much protein is produced, and it can be identified using immunohistochemistry. So you can take slides and stain, or using next generation sequencing. And that includes things like PD-L1 expression, which is a biomarker for immunotherapy in some diseases, has not been proven to be a biomarker in a lot of, in biliary tract cancers, but at least in other diseases, for example. So when we talk about molecular testing, there's some key information we should remember. Molecular testing, I think the Cholangiocarcinoma Foundation did a great job and a great campaign, because there's so many different words and languages and vocabulary around biomarker testing, next generation sequencing, genomic profiling, genetic testing. But all of this refers to a variety of methods that basically summarize the genetic changes that occur in a tumor, like mutations and fusions and things related to cancer. You can also identify genetic changes in your tumor by basically, the molecular testing helps identify genetic changes in your tumor, and that can specifically give information to your physician about treatment options, and in some cases, prognosis, because certain genetic changes inform us about how a disease course may run. Molecular testing can be performed using tumor collected at the time of diagnosis. I think that's a very important thing to remember. This is not something that requires fresh tissue that you have to undergo an additional biopsy for. That being said, sometimes there is findings of insufficient material for testing, and that may require additional needs for biopsy. And it is typically performed at the time of cancer diagnosis, but we are also learning about the role that it can play after initial cancer treatment at the time of progression. There could be some validity or utility to determining whether or not there are additional changes in your tumor genetic makeup that could help inform subsequent therapies. I think it's also important to point out that we're getting better at getting these costs covered. Costs are often covered by Medicare and insurance with minimum out-of-pocket expenses now for our patients. And these results need to be gotten to your physician and help you need to be informed and the physician needs to be informed of these results as soon as possible because it has implications for how we approach our patients. The molecular testing, like I mentioned, it's a catch-all phrase. So I now use biomarker testing, but there are a lot of other names used: genomic profiling, tumor profiling, mutation profiling, tumor next generation sequencing. And then of course, there is the idea of all the different platforms. And sometimes that's what people say is, oh, did you get your Foundation One done or your Tempus or your Acaris or your Oncomine? But I think it's important to remember that all of these types of words, phrases, et cetera, all speak to molecular testing of your tumor and are an important part of personalizing the physician's approach to cholangiocarcinoma. The Foundation One test is one example here. And so I put this up primarily because it is probably the most commonly used test because it is a companion diagnostic test, meaning it is an FDA approved test. So the Foundation One companion diagnostic was FDA approved in 2017. And it is basically it is performed on tumor tissue, archival, for instance. So your biopsy that you had at the time of diagnosis can be sent to the company. They extract the DNA from the tumor and then do a very comprehensive look. As you can see, this is the current gene list of 324 cancer-related genes. And this includes all of those different genetic changes that we talked about: mutations, gene amplifications and deletions, gene rearrangements or fusions, as well as important things that are related to immunotherapy approaches like microsatellite instability and tumor mutation burden. And like I said, as you can see, there's a very comprehensive list that is used and included. Some of these are absolutely actionable, like you'll see IDH1 here, for instance. You'll see the FGFR2 gene fusions and the rearrangements are identified here. But then there are some that, are incredibly relevant in terms of genetic dysregulation, but for which we do not have targets yet. And so hopefully, as we continue to understand the implications and the presence of these genes, drug development can shift to focus on those spaces. So let's talk specifically about cholangiocarcinoma. Like I said, there are genetic changes in pretty much everyone with cancer in their tumor, but an actionable genetic change is one that is a cancer-related alteration that informs treatment decisions or potentially disease prognosis. But I specifically think of an actionable genetic change as one for which we have drugs. So FGFR2 fusions are actionable genetic changes. Why? Because we have FGFR inhibitors. When we have done comprehensive profiling of multi-center approaches to looking at cholangiocarcinoma, it's about 50% of patients with cholangiocarcinoma that have an actionable genetic change and could have something targeted with a drug that is available either in clinical trial format or FDA approved. Surprisingly, however, and this is, I'll be honest, as somebody who treats a lot of cholangiocarcinoma, it boggles my mind that despite the number of patients who could benefit from molecularly targeted therapies, you would be surprised at the number of patients who are newly diagnosed who undergo molecular testing. And so I would say the foundation has done a tremendous job, Melinda and Stacy and everybody, at doing everything they can to educate everyone, patients, caregivers, physicians, providers, everybody, about the importance of molecular testing at the time of diagnosis. This table here, I think, is a nice summary of the most commonly found targetable genes, what their function is, as well as their prevalence. And as I mentioned, FGFR2 fusions are probably one of the more common and relevant because it's actionable genomic alterations. The prevalence is 10 to 15% is kind of what I quote. I'll be honest, that number is a moving target. It may be closer to the 10% range. We're still trying to figure out exactly what the incidence is. There are other fusions and rearrangements that are actually seen in other tumor types as well, and have targets and targeted therapies available that have been looked at in other tumor types and or are what we call tumor agnostic. So NTRK fusions, for instance, drugs like larotrectinib, et cetera, are approved for any disease with an NTRK fusion. That being said, these are very rare. The other more common mutations, for instance, are IDH1 and IDH2. We see that I usually quote about 15 to 20% of patients. And then you can absolutely see changes. This is HER2. So HER2 mutations as well as amplifications are definitely rarer in cholangiocarcinoma, but still make up probably about 7 to 10% of especially extrahepatic cholangiocarcinomas. And then you see a smattering of other things, smaller numbers, but still important, like BRAF, because dual BRAF and MEK inhibitors like dabrafenib and trametinib are highly effective in patients with BRAF mutations. As I mentioned, MSI high is really rare. We see it about 1%, but it's important to know if it exists because of the immunotherapy options available. Same with tumor mutation burden. Tumor mutation burden high suggests response to immunotherapy. Again, probably 1% or so of cholangiocarcinomas. So let's talk about the drug development space. So patients actually have incredible treatment options now in cholangiocarcinoma, and I can't help but smile about it because it's been 2 years of just rapid pace drug development. So you can see when a patient receives a diagnosis of cholangiocarcinoma, they absolutely need to undergo molecular testing. And depending on what alteration is found, there are drugs available. There are FDA approved drugs. In the FGFR2 fusion space, we have pemigatinib and infigratinib. Fumagalli just got a PDUFA date, so possibly we'll have 3 drugs, FGFR inhibitors available for our patients. IDH mutations, we've got ivosidenib FDA approved. And then there are things that are FDA approved in other disease indications, but that could be available to patients, such as ERB2 amplifications with drugs like trastuzumab, BRAF mutations, like I mentioned, et cetera. The clinical practice guidelines absolutely suggest the need for molecular testing for patients with cholangiocarcinoma. And we've been working with the NCCN to make that a stronger statement because I think it's imperative. So let's talk quickly about infigratinib. This is the data that was initially presented in 2021. It is the data on what was initially known as BGJ 398 and is now known as infigratinib. This was a single-arm phase 2 study that looked at infigratinib, which is an oral ATP binding competitive kinase inhibitor of FGFR. There was a lot of great preclinical and early phase clinical data that showed that infigratinib was safe, well tolerated, and worked by itself. Safety data actually is now available in over 900 subjects, in fact. So this is the phase 2 study. This was patients with FGFR2 gene fusions or rearrangements. This is cohort 1 with a planned 120 patients who received infigratinib monotherapy. And we were looking primarily at objective response rate. How much did tumors shrink? This is the waterfall plot. This was blinded independent review. The objective response rate was 23.1%. And you can see, in the waterfall plot, most patients derived some benefit from infigratinib. Stable disease was an additional 66%. So, really, really active drug. And what I think is important to point out is a refractory patient population. These are not newly diagnosed patients. These are patients who have gone through a number of lines of therapy. Importantly, the safety profile also was kind of what was expected and what had previously been seen. So there's class effects with FGFR inhibitors. These are primarily the calcium phosphate homeostasis. You can get hyperphosphatemia, high levels of phosphate. You can get some tissue calcification, some eye disorders, ocular toxicities. The ones that we thought of that were kind of scary were actually not so common, thankfully. But this is a drug that definitely requires serial ophthalmologic evaluation and a partner in crime from ophthalmology. The more common side effects were things like fatigue, stomatitis, so soreness and sores in your mouth, dry eyes, and kind of nail bed changes. The PROOF trial, on the other hand, is the ongoing trial. The PROOF trial is a phase 3 study. So the initial study was a single arm phase 2 study that led to what we call accelerated approval of Infigratinib. The PROOF trial is the phase 3 open label randomized control study looking at Infigratinib versus gemcitabine and cisplatin in patients with advanced cholangiocarcinoma and known FGFR2 gene fusions. In this study, patients who have been diagnosed with cholangiocarcinoma that is locally advanced, unresectable, or metastatic, so advanced patients who have undergone comprehensive next generation sequencing and have been found to have an FGFR2 gene fusion or rearrangement, are allowed to be considered. They cannot have had prior therapies in the advanced setting. However, the study has now been modified to allow for one cycle of gemcitabine-based therapy prior to randomization, because we need time. We need time to complete the molecular testing and to identify patients with FGFR fusions. And basically what we're trying to understand in this study is, how does Infigratinib stack up, if you will, against the standard of care of gemcitabine and cisplatin? Do patients with FGFR2 gene fusions need chemotherapy, or can they receive targeted therapy? This is the study design and the schema. So like I said, frontline patients with FGFR2 fusions, randomized 2-to-1 to receive Infigratinib versus gemcitabine and cisplatin. So patients are randomized again after having the option to receive upfront chemotherapy for one cycle to allow for time for identifying these patients. And then the primary endpoint is progression-free survival. There is an option to cross over to the Infigratinib arm for patients that are on gemcitabine and cisplatin, which is why progression-free survival is a smart endpoint. And then secondary endpoints, of course, we're of course interested in overall survival, as well as all of the other important questions when it comes to efficacy, like response rate. So I think this phase 3 study is obviously key. Number one, it is a confirmatory study for the FDA. But I think there's important questions. Why is a control or comparator arm needed? We need to understand, do these patients do better with targeted therapy than gemcitabine and cisplatin? I don't think gemcitabine and cisplatin is going anywhere. I think patients will at some point in time need to receive gemcitabine-based therapy. But here's a great idea. Can we treat our newly diagnosed patients with a pill instead of IV chemo? I think the randomization of 2-to-1 is really important. It gives our patients with FGFR2 fusions a 2 out of 3 chance of getting Infigratinib up front. And then I already mentioned why we did the one cycle of gemcitabine-based therapy. It's really important that we do not withhold therapy. We need our patients to be able to feel comfortable to be considered, to be treated while they're being considered for this trial. But I do think that this study will absolutely inform us as physicians, the patients, the community, about the potential benefits and risks of Infigratinib and what it does and how it stacks up against our standard treatments. Follow-up is going to be really important. Progression-free survival is an endpoint that is a little bit tricky. We need to make sure that we enroll patients and follow them very carefully, as well as, of course, quality of life. That is such an important question for our patients and for our community. How does this drug make one feel? What does it do to quality of life? You can see that this is a global effort. It is all over the world, including Europe, Asia, and North America, as well as Australia. So there's sites that are participating everywhere. Everyone is really committed to kind of understanding and getting the answer to the question of FGFR therapy versus chemotherapy. And for those interested in the United States, this is open across the country. There are a lot of sites. There's 25 sites in the US. I'm privileged to have this open at University of Arizona Cancer Center, but it is hopefully available to any patient that is interested in it. And with that, I will turn the mic back over, and I'm happy to take any questions. Thank you all.
Thank you, Dr. Shroff. That was great information. We do have some questions that have come in. So for Stephanie, this has been recorded so that you will have access to watch it again for the slide question. And then, can you please explain ctDNA and how it should be used?
Sure, that is a $1 million question. I will tell you, so ctDNA is circulating tumor DNA. It is sometimes referred to as cfDNA as well, cell-free DNA. The idea is that cells are available and DNA from tumors are available via blood. So ctDNA is another word for liquid biopsy, essentially. And the idea is, instead of using tumor tissue and taking a needle core biopsy from the liver, for instance, you just do essentially a blood draw. And so there's a lot of different companies that have developed platforms in this regard. And there's I would say some people who have been doing it sooner, but there's not necessarily one company leading the charge in this. It's a really all-out effort to develop this technology. But the idea is sequencing the DNA from the blood and doing that whole same comprehensive molecular testing using blood. By and large, the panels that are available today are not as large, for instance. So compared to the 342 genes that Foundation Medicine looks for, there is a smaller, usually on the order of 100 or 125 genes that are identified using ctDNA. The trickiest part to me, the reason that I don't necessarily go to that first, is simply that the sensitivity for things like FGFR2 fusions is a little bit lower, meaning you don't detect all FGFR2 fusions. And it's getting better. I will tell you, every year the technology is getting better and the sensitivity for FGFR2 fusion detection is getting better. But until, this is, for you all, for us, it is a very important alteration to find. And so the thought of missing it is just not acceptable to me yet. So I always go for tissue first. If for some reason I cannot get tissue-based next generation sequencing, ctDNA is absolutely where I go to next. And I will also say that there is a huge research effort right now, not only to improve the technology, but to understand how ctDNA can be used to understand resistance that develops from, say, FGFR-directed therapies, as well as detection in the post-operative space. So once you've been cured of cancer, can we use ctDNA to test for, God forbid, is this cancer coming back, and that sort of thing.
So Dr. Shroff, is ctDNA and MRD the same?
Not exactly, but it's using the same technology. It's looking for circulating tumor DNA, but ctDNA, I think, is a broader term as opposed to platforms that develop the use of ctDNA to detect minimal residual disease in patients who are post-operative.
Okay. So next question, and I hear this a lot. For patients who have had resection, should they have the biomarker testing done on the tumor that was removed, or do they wait in case the cancer comes back? What do you feel about that?
Well, I think, the point that's made in this question, the trickiest part is actually getting it paid for in patients who have undergone resection. So in people who do not have active disease, who have early stage disease, and it's really frustrating. Just so you all know, I feel your frustration, because I would happily send that tissue off for profiling. God forbid this cancer comes back, I'm not scrambling. I will give kudos to Proof, as well as a lot of the other frontline studies, are allowing surgical tissue to be sent and be kind of pre-screened, if you will. And so that is being covered by that trial. The honest truth is most of these alterations, FGFR2 fusions, IDH, et cetera, these are early drivers. They are found early in the development of what we call cholangiocarcinogenesis, and the progression and development of cholangiocarcinoma. So these fusions, these mutations are typically found even in early stage patients. So if we have the ability to do it, I like to do it.
Wonderful. Okay. Do you have any updates on the Basilia trial for Derazantinib?
Yeah, so the I think it was called FETUS or FIDUS, I don't know how to pronounce it. That data was presented at ASCO, I think, last year. And the honest truth is all of these FGFR inhibitors, Response rates are in around the 25 to 35% range. Futibatinib's updated data looks slightly higher at 40% or so. But I believe derazantinib was also in that range. I think it was around 30%, actually a little bit less. As far as I know, I don't believe they're moving derazantinib's development in cholangiocarcinoma forward, is the last I had heard.
Okay. Thank you. So what has brought about neoadjuvant chemotherapy? Our community has seen patients have chemotherapy prior to surgery in hopes of shrinking the tumors to get better margins, but sometimes the chemotherapy is not effective and the tumors grow and the patient becomes ineligible for surgery. Is it worth the risk to wait for surgery?
You know, that is such an important question and is like the classic clinical dilemma that we deal with every day. I will tell you, the other hat I wear is pancreas cancer. And so we've been doing preoperative therapy in pancreas cancer a lot longer than what we're doing so far in cholangiocarcinoma. And the honest truth is that the general statement that we give is, in some ways, preoperative therapy is a test of the tumor biology. So in pancreas cancer, for instance, patients say the same thing, well, I had the tumor in place and you could have cut it out and now it's grown or it's metastasized, God forbid, to the liver. And our feeling is generally, well, if it grew through chemotherapy and metastasized through chemotherapy, we could have put you through a Whipple, which is the huge surgery that we do for pancreas cancer. And then on the first scan, you probably would have had metastases, because the honest truth is there's probably microscopic metastases that are not visible on imaging that are already brewing or already spreading, if you will. And so while I can completely understand, because the physicians feel it too, that devastation of, oh, we could have operated and now we lost our window. I think it's important to kind of think about, well, at the same time, if you would have probably progressed or recurred or had the cancer grow quickly or come back quickly, maybe perhaps we've spared cutting out half the liver and putting you through that big resection. And so the idea of neoadjuvant or preoperative therapy is, there's a lot of reasons to consider it, but a lot of us think of it as a litmus test for the tumor biology. How mean and nasty is this tumor? And, are we truly helping by doing surgery?
Right, I know. That is a tough one. If a patient has a successful resection, would there be benefit to have targeted therapy as adjuvant treatment instead of chemotherapy?
So you guys are asking all the questions that we all have. That is such an important question as well. We think so. The general sense is at least when you look at the data with Infigratinib, for instance, with 23% overall response rate, but when you look at the 46% of patients who had Infigratinib in the second line setting, so had it right after one line of therapy, it's a higher response rate. It's closer to 35%. And so the idea of proof and the other frontline studies is the earlier introduction of targeted therapy seems to result in higher efficacy. It seems to shrink tumors more, have better response. So then, of course, the obvious question is, well, would it be beneficial then in patients who are cured to give Infigratinib, for instance, in the postoperative setting instead of, say, capecitabine? So we're asking that question right now. Okay, I have to get the name right. The OPTIC study is a multi-center study. It is not open yet, but we're going through the processes of opening it. Dr. Shashir Maithal and myself are the co-lead investigators. He's at Emory, I'm at University of Arizona, but it's going to be open across the country. And the idea is to randomize patients to receiving perioperative, neoadjuvant actually, Infigratinib before a surgical approach. And if you are identified to have an FGFR2 fusion, then you get Infigratinib. If not, you get GAP, which is Gemcis and nab-paclitaxel. And then from the NCI level, the NCI Hepatobiliary Task Force, we have been trying to design and figure out what the right way to answer the question of adjuvant postoperative targeted therapy is, because we do think that there's probably a role.
Wonderful. Okay, can you talk a little bit about the timeframes in receiving the results from molecular testing? I hear it can range from 2 weeks to 6 weeks, just depending on how it's done.
I think tissue is definitely slower than liquid. So that's another plus. The CTDNA turnaround tends to be like 7 to 10 days. Tissue, I think the biggest holdup, I will say most of the platforms, Foundation, Caris, Oncomine, all of them have gotten quite good. It's usually about 2 to 3 weeks once it's in their hands. The problem is getting it in their hands, right? Because a lot of our patients, we're a referral center. So I have patients who get referred to me and the tissue is not sitting with me. The tissue is sitting at the place the patient was diagnosed. So then the tissue has to be requested by me, then that tissue gets set. I mean, it just has to pass through a couple set of hands. And that's, I think, what adds to the timeline. And so the timeline that I typically quote my patients is about 4 to 6 weeks. The worst, I will be honest, the most frustrating part is after 4 to 6 weeks, you get that quantity not sufficient, and you find out that you couldn't even get the comprehensive profiling and you have to go through a biopsy or whatever it is. But by and large, we quote 4 to 6 weeks. If the tissue, like if I'm doing a fresh biopsy and am able to order it and then send it out, it's probably closer to 4 weeks, like max, like 3 to 4 weeks.
Okay. And so I guess that brings me back to 1 cycle of gemcitabine cisplatin for the trial. What is the time frame for 1 cycle? Does that give us enough time to get that testing done?
Yeah, I mean, I think that the general sense is 1 cycle is 3 weeks, right? And then you tack on the pre-screening and the week or 2 that happens of getting a patient consented, getting a port in, like all the other things that we are doing to get somebody started on therapy. And I think that's where it comes up to about, 4 weeks, maybe 5 weeks. And that hopefully is enough time. I mean, I don't know, Luca, if you have other thoughts from Helson's perspective on that, but I mean, it hopefully gives you, it definitely gives you a better shot than no chemo, but I don't know, Luca.
No, thank you, Donna. That's exactly the point. We get many advice from investigators and good doctors like you that they are struggling and having a sense of urgency to initiate a kind of treatment with patient in need. In the first line, they cannot wait the 4, 6, 7 weeks needed for the whole screening process and the molecular diagnostic testing. And that we all agree that that could be an option to keep safe patient, allowing them to have at least 1 cycle of standard chemotherapy without affecting too much, in a way, the general evaluation of the drug in this indication. And that's exactly why we introduced this type of amendment, just to allow patients to keep safe, have a kind of treatment while waiting if they are potentially eligible to a more targeted approach, like with Infigratinib. That's exactly as you explained.
Very appreciative. At least we feel like we're doing something. So there's a lot of questions, and this comes up a lot with the patients in the support groups and stuff. How do you choose which FGFR treatment inhibitor to use? Trial first, FDA approved first? Is there an order? Can you benefit from more than one? How does that all work?
Yeah, I will say that there's, to me, so far, with the 2 FDA approved drugs, and Helson may not love that I'm saying this, I don't have a difference. I don't see a difference per se. I think it is apples and oranges to compare separate trials. And so it's really easy, even if Fumagalli comes into play, it's going to be really easy for us to say, oh, but the response rate is slightly higher in X versus Y. But I think they're different patient populations, they're different trials. And so, you have to account for the margin of error that occurs when you're looking at 3 separate cohorts of patients. I think all of them are very good drugs. I think they all have very similar safety profiles. I think pemigatinib has been in the community longer, so it's very possible that some people might gravitate towards pemi, but I don't think that's because it should be that way, or better, that it's better than Infigratinib. I have been using Infigratinib since it was BGJ398 back when I was at MD Anderson. So I probably have given more Infigratinib than I have pemigatinib. And so I feel very comfortable with that. There are some people, from a patient perspective, some drugs are daily dosing and some are 3 weeks and then you wait a week. And so from a compliance perspective, they're like, oh, but this one's easier for the patients to remember. But again, I don't necessarily think that it's because it's better or worse than the other. In terms of sequencing, gosh, we hope so. There's nothing worse than having 3 drugs available to us and feeling like we can only use one of them. There is, and this is where I was talking about the CTDNA, there's some beautiful data that came out of MGH with Dr. Boyle, and, all of us, it's a small community and we all talk. And so myself and Dr. Javle, when we had BGJ398 at MD Anderson, we would put patients on the BGJ398 trial, and then they would have these great, wonderful responses that they were on the drugs for a while, and then they would come off, and then we would send them to what was the phase 1 trial at the time, which was Fumagalli. And then they would have these fantastic responses to futibatinib. So we do believe, I mean, if you ask Dr. Jogley and me, he and I go through all of them eventually. But we're trying to understand the science behind that. Like, is there a rational way to sequence these drugs? At the end of the day, they're going to all be FDA approved for kind of second line and beyond. So hopefully we'll be able to strategize about what makes the most sense. Without getting into too much of the science, pemigatinib and infigratinib are both ATP binding competitive inhibitors, and futibatinib is a covalently bound inhibitor. So it binds in the FGFR space a little bit differently. And that is probably why we think it makes sense for patients who did respond to infigratinib, who could then subsequently respond to futibatinib, because the resistance mechanisms that develop with infigratinib affect where infigratinib binds, but doesn't affect where futibatinib binds. So I do think we will get to the point where we understand how to use all these drugs. And that's kind of where there's a lot of research effort right now. But I you know, when we see these patients in clinic, we try to make sure that we get our hands on as much as we can, because they all seem to work.
Great. Is this helpful for CHEK2 variant?
So not FGFR inhibitors. You know, CHEK2 is part of a DNA repair pathway. So when we look at alterations in the DNA repair pathway, the most well-known one is BRCA mutations. When you put all of those together, it's about 20 to 25% of biliary tract cancer patients that have alterations in the DNA repair, what's called HRD pathway. And so there's a lot of studies looking at things like PARP inhibitors that are targeted therapies that, you know, are FDA approved in BRCA mutated pancreas cancer and breast cancer and things like that, trying to see if PARP inhibitors work. There's some suggestion that immunotherapy with PARP inhibitors, and so there's some trials in that space, but not FGFR targeting therapy. It's a different class of targeted therapies.
Okay. So is it possible for a patient to have IDH1 and FGFR2 mutations?
Very rare. You know, it's interesting. We used to say they were mutually exclusive because we did not see patients. But then I will say I've seen maybe a handful. I have one patient that I can think of specifically that I share with University of Utah. And, you know, they're both early drivers. And so it's very rare to see both of them. But by and large, they are separate.
Okay. Bobby was asking about infigratinib's availability. So infigratinib is approved second line right now, but the trial is first line, correct?
Correct.
Okay.
The ongoing trial is for frontline patients. FDA approval is for after frontline, after Gemcis.
Okay, we talked about that one. She probably missed this, but what prior treatments would rule a patient out for this phase 3 trial?
So basically anybody that has had a therapy other than Gemcis or has had more than one cycle of Gemcis.
Okay, so I think we covered a lot of these. I think we've already covered. Which should be the diet for patients who have this disease in the advanced stage?
I mean, in general, the diet, I mean, I can't, there's so much research and data going on in this space. I mean, I tell my patients, I don't give specific dietary suggestions. I say, focus on protein and calories. We want you to keep your weight and energy levels up. In the FGFR space, when patients are started on an FGFR inhibitor, we recommend that they start a low FOS diet, which I have to be honest, if you're really strict about it, is actually quite restrictive. I was very surprised, but you don't actually have to be as strict as we thought you did when we started patients on BGJ 398. But, you know, there are things that are high in phosphorus, like soda, for instance. And so things like that you should avoid. If you develop the hyperphosphatemia, you know, usually we start patients on what are called phosphate binders, which are pills, and that usually helps take care of it. And the clinical significance of hyperphosphatemia is actually pretty low. So a low phos diet, I don't tell my patients they have to be as strict as we initially thought, but that's the main change in the diet.
Okay, and I'll just throw a plug out. We have a nutrition resource coming out really soon. So you guys watch for the notices on that, and we will let everyone know. And it talks about the low phosphorus diet and other helpful hints for treatment and stuff. So put that plug out there. And while we're talking about diet, what's your thoughts on sugar?
You know, that's such a tough question. I know that there's a lot. I used to say that it was urban legend, because there's all these things that were out there that sugar feeds cancer, and but PET scans are using sugar, and PET scans light up with cancer, and I firmly believe everything in moderation. Like, do I think that you need to completely eliminate sugar from your diet? God, life without ice cream.
I would cry.
Sounds miserable to me. I can't imagine life without ice cream. So, I think everything in moderation. There is no data that says that, sugar drives growth of cancer. That's not, it's just not that cut and dry, at least directly. And so, do I think that you need to have a diet that's rich in fruits and vegetables and lean meats and all the other things, lean protein and all the other things that we talk about? Yes. But as I say to my patients all the time, that's also what I would recommend to your loved one who doesn't necessarily have cholangiocarcinoma, right? Like that, just a healthy diet and everything balanced.
Great. Okay, so what are the implications of these therapies for those who are not MSI high or TMB low? I don't think there is, right?
No, I'm assuming the question is related to immunotherapy maybe, but so, it is, to me, cut and dry if we find microsatellite instability high and TMB high. Those patients absolutely need to get immunotherapy. Which other patients should get immunotherapy is it's a hot question. We don't know, Topaz 1 suggests that everybody can get durvalumab. Those of us in the community feel a little less convinced on that question because when you do look at those curves, it's really about 25% of patients who really derive that benefit. And there's a lot of biomarker analysis right now happening with Topaz. They're doing a deep dive to see if we can understand what markers might suggest who these patients are. We do, this was a global study, and 52% of patients who received durvalumab were enrolled in Asia. And we do know from comprehensive immune profiling that the Asian patient population is more what we call immunogenic, more susceptible probably to immunotherapies. So is that 25% a bunch of patients that were enrolled in Korea? We just don't know yet. And so I think that's going to be something that I cannot wait to see them pull out the biomarker analysis so we can understand which patients should be getting immunotherapy.
Okay. And I just want to clarify, this question is for someone who has had 4 months of GemCis. Does that mean that they are not eligible for Infigratinib? It would only mean they're not eligible for the first line trial, but they could still get Infigratinib second line.
Absolutely. Absolutely. So if you have an FGFR2 fusion positive cholangiocarcinoma, Infigratinib is available to you after gemcitabine and cisplatin. That's, that proof is a totally separate trial. The Infigratinib is available.
Okay, perfect. There was some confusion there. And then I have a question. Is there any data or science on, I see so many young women who have the FGFR2 fusion mutation. Is there any science or anything to say why that happens, or is it just something that we see?
We don't know yet. There's a whole natural history effort. I know you know about it, Melinda, but it's a multi-center effort. And yeah, the median age of diagnosis is in the 50s. It's a female predominant. It seems to be a white female predominance. These patients tend to lean towards more bone metastases. So there's definitely a clinical profile. Not everybody fits into that profile, to be clear, but that is the general profile. And now we are starting to kind of do the analyses, the biomarker analyses, risk factor, epidemiology, all these questions to better understand it, but we don't know yet.
Okay, last question just came in. We're running out of time. Have you ever seen someone who is not MSI high, but then through NGS, it changes in the future?
That's yes, I have. That's my short answer, but it's a rare thing. So basically the idea of microsatellite instability high and tumor mutation burden is related to the general instability of the genome of the DNA in a tumor. And there is some science that suggests by applying pressure, and that pressure comes from chemotherapy, targeted therapies, whatever you're treating the patient with, that you create a more and more unstable or unstable genome. The amount of times, though, that I've seen that translate into a high tumor mutation burden or even rarer microsatellite instability high, I can count on one hand. it's pretty rare. Microsatellite instability high is kind of at the time of diagnosis and doesn't change very much. Tumor mutation burden can evolve, but also exceedingly rare.
All right. Thank you both so much for your time today, for the presentation, for answering all the questions. And for the audience, if you have any further questions that come up later, please shoot them my way and I'll try to get them answered the best that I can. And the video, the presentation will be recorded and you'll have access to it probably within the next few days or so. Thank you guys again for your time. We appreciate you so much. Have a wonderful day.
Thank you, everyone.
Thank you.